Hi everyone, welcome to the virtual job shadowing workshop of the MedVenture conference. Today we have Dr. Nicole with us, and she is a general surgeon at the Sunnybrook Hospital. I want to thank Dr. Nicole for taking time out of her day to be with us today. Dr. Nicole, do you want to introduce yourself and maybe give a brief outline of what you will be talking about today?
Sure. So thanks, Elaine, and welcome everybody. A pleasure to be here today. I am a general surgeon and surgical oncologist in Toronto. I'm affiliated with the University of Toronto. And at least the job that I think I was charged with today is just giving you a little bit of an introduction about what my life looks like, kind of on a daily and weekly basis. Kind of what my background is, and I'm certainly open to questions if anyone has anything to ask as we go along.
Okay, thank you. You can take it away.
All right, perfect. I'm just going to put up some slides here to share with you. Everyone can see it looks okay? Yep. All right, perfect. So like I said, it's Sunday afternoon, so it's totally casual. Interrupt and ask anything you want to as we go along. No question is silly, no question is too small, so feel free. So what I was briefly going to talk about today, a little bit about my background, a little bit about what a typical week in my life looks like. I have many hats that I wear, including surgical practice, a clinical surgical practice in cancer, as well as some connections to industry and consulting, which I think is why I was kind of pulled into this conference in the beginning. And then I also have another life in kind of academics related to the University of Toronto, so I'll talk a wee bit about that. I'm going to go over some of the rewards and challenges that we face in surgery, and then it's certainly open to questions at the end. All right, so move this over a little bit. Just a brief snapshot into what my pathway was to where I am today. I believe all of you are kind of high school aged and around that. So if we start back where you guys started out, after I finished 4 years of high school, I went to an undergrad degree that I spent 3 years in, but many people spend 3 to 5 years depending on what their specific program is. If one's interested in a medical career, then certainly there is openings for any types of undergraduate degrees, but certainly specific prerequisites are always a good thing to pay attention to. After undergrad, I went straight into medical school, which was 4 years in the school that I went to, but there are many others who do a graduate degree, a master's, a PhD, and potentially even a postdoc if they're interested in doing that. And that is an introduction to them going to medical school later on down the line. So there's no perfect path. There's many ways to get there, lots of opportunities and options to pursue. After medical school, one has to choose some kind of specialty. And so I chose general surgery as my specialty, and that residency program at baseline is about 5 years, depending on which school you go to. In Toronto, it's 5 years. In BC, for example, it's 6 years. So every school has their own particular surgical residency program. Family medicine, if you choose that, is 2 years. That's why I put 2 here. Something like neurosurgery, for example, is about 9 years because it usually incorporates a PhD. So there's a whole gamut of training durations that you might see. During my residency, I took 2 years out in the middle of it to do a graduate degree. So I did a master's in the middle and then came back to my residency. So that's why this is kind of sticking up here. Following that, I did an extra training fellowship in surgical oncology. So that's after graduating your residency and becoming fully licensed. And then only after that, I kind of get my first job. And some people say, well, oh my goodness, that's many years where you're not getting paid and you're not earning any money. And it's true in a way, but usually once you start your residency within these years, you do get paid as you go along. So you are able to, pay your rent and feed the people in your house, and all of those obligations that you need to fulfill as well. So how do I move forward here? In total, it took me 15 years to kind of get from high school to my first job. So just to give you an idea of what that journey might look like. So I wear a lot of hats on a daily and a weekly basis, and this contributes to how I enjoy my life. But I'm an academic surgical oncologist, so I work in combination with the University of Toronto, and I'm also affiliated with one of the academic hospitals called Sunnybrook Hospital. So as a clinical surgeon, I work as a surgical oncologist, so a surgeon that specializes specifically in cancer surgery. And I have specific training and qualifications specifically in cancer surgery. And within that, I have a focus on breast cancer and melanoma as the two types of cancer that I treat most frequently. I also used to do a fair bit of general surgery call. So this is like after hours call, anything that comes in the door, appendicitis or any of those types of things. But I have kind of swayed away from that a little bit to focus on my specialty practice. Second thing I do, I'm a researcher in health research, and this is where I did my master's in the middle of my residency. So as a clinical epidemiologist, I have training in the conduct of health research. Specifically within that, I do a fair bit of health economics and policy work. I have a specialty in qualitative methodology, and I also do health services research, which is basically like big databases of patients and their outcomes that we use to generate healthcare research. I also have an appointment within the School of Public Health. So I direct one of the courses within the School of Public Health, and that's all with the background of being the clinical epidemiologist. As an academic, I also, like I said, have an appointment within the Department of Surgery at the University of Toronto. And this means that I have the opportunity to teach students, teach residents, and teach fellows. But along with that, there are certain obligations with respect to my research productivity and the teaching that I must do. And there's evaluations that go along with that too, in order for me to maintain that academic appointment. I also direct one of the surgical fellowships within the university. So that's a bit of an administrative role that I chose to have as well. The last thing on the list, I do some kind of surgical innovation. Both it started out as a research project, but the receptor company that was created out of that research is called Molly Surgical. And so once that receptor company was created and kind of took our product forward, I now kind of sit on the consulting board for Molly Surgical. So it's a little different role than in the university. I work in cancer, so I do have relationships too with some drug company advisory boards, and so I do a little bit of consulting work for them as well. So lots of different hats, lots of different things to do, and it keeps my life interesting. So last week, you can see it was a pretty quiet week, to be frank, but lots of different things going on every week. I'm going to focus a little bit on each of these things in turn so that you have a better idea of what I do. As I told you, my practice focuses largely on breast cancer and melanoma. And this is a little bit about breast cancer and how we often will counsel patients that we see in terms of how we treat them. And it also spills into what I do on a daily basis. So when we see patients who have breast cancer for the first time, one of the first things we always tell them is that their treatment will often encompass several different themes. So they are likely to have some component of surgery and potentially chemotherapy, some component of radiation therapy, and then usually some component of biologic therapy, so usually a targeted oral therapy. And so different doctors have different concentrations in each of these things as one's treatment goes along. And the cool thing is that I get to work with all of these individuals on a weekly basis. So the surgery and chemotherapy part often has to do with cutting out the offending tumor and then giving drugs and medicines to try to prevent recurrence or cancer coming back. Radiation therapy often has to do with giving different types of radiation treatment, again, in order to prevent cancer from coming back. And biologic therapies are often pill-type therapies that people take for 5 to 10 years. So when one has treatment for breast cancer, often this therapy can extend anywhere from about 6 weeks to about 9 months to 10 months, depending on the intensity of their other therapies. So we have the opportunity to treat people through a sequence of different therapies. And I have the opportunity as a surgeon to work with medical oncologists or chemotherapy doctors, radiation oncologists, as well as a whole host of other multidisciplinary people. So specifically about breast cancer surgery, which I have the most to do with, these are some of the options that we give to patients that I talk to them about on a routine basis. So the basics of this is basically, if you have a cancer in your breast, you can either cut it out and save the breast, or you can take the entire breast away, kind of the basic principles. We know that breast cancer is closely related to lymph nodes as well, and these are mostly in the armpit, or the axilla, we call them. And so we often sample lymph nodes in the armpit as well. One of the important things about breast cancer, we're lucky that we have screening programs in Canada, and therefore they're often detected very early, things that I can't see or feel from the outside. And so this area, and I point this out specifically because it has to do with the technology that I'll talk about later. If one has a cancer that's so tiny that I can't feel it, we often have to use tools for what we call localization. So tools that surgically help us to detect and find the tumor, and then target surgeons to the right place so that we can take out the right spot. So it's kind of like breast cancer GPS in a way, figuring out where the problem is and helping surgeons to go where they ought to be. So I'll come back to that a little bit later. So like I said, in general, when we treat people for breast cancer, the two main options are to we have to identify the tumor first, and this is a mammogram that would look at that. We either take out just the area where the cancer is and leave the rest of the breast behind. So this is a X-ray of the area that's taken out, and this is kind of what it looks like in real life. The other option is if you have a cancer, you can take out one's entire breast as a mechanism of surgical treatment as well. So there are obviously pros and cons to different options, and that's my job to talk to people about that and help them make a decision that is not only good for their cancer, but is good for their overall quality of life, and help patients to make the right decision for them. When we take entire breasts away, we also talk to people about breast reconstruction. So either with implants, reconstruction can be done to make a new breast, or something called autologous tissue-based reconstruction, meaning using another part of one's body to create a new organ. So in this scenario, we're using tissue from the belly to create a new breast, and to create a matching breast after we have to take one away for cancer. So this is a really cool kind of creative opportunity that we have as cancer surgeons to work with plastic surgeons, and to not only treat people's cancer and hopefully cure them, but also make them feel like they're reconstructed and as whole as they can be. It's a really fun part of my job. Like I said, we often test lymph nodes, particularly under the armpit, because they're most closely related to breast cancers. And so we do often something called a sentinel lymph node biopsy to target and take out lymph nodes that are related to one's cancer. So in real life, this is what a sentinel node looks like. We often use a combination of radioactive dye and this blue glowing dye to identify lymph nodes that are of concern. And then this is the indication to me that this is the one that needs sampling. It needs to be taken away. So this is what I talked about a little bit before, is that sometimes people have cancers that we can't feel or see easily. And therefore we have to use tools to help surgeons identify the area to be taken away. So one of the oldest tools that we use are these wires that have hooks on the ends that are used to mark the area that's concerning. So in this case, this area right here, and then take that area away. So we can use this. This comes out the surface of one's skin, and then we use this as tools to take out the right spot. And sometimes we can use these as kind of bookends to mark the top and the bottom, or the middle and the end of an area that's abnormal, and again, use these as markers to take away the appropriate area. I see one person on the chat. Anyone has questions? For sure, let me know if there's questions. The other option for a localization that we sometimes use as well is something called a radioactive seed. So these are little, they're almost like grains of rice, and they're impregnated with iodine-125, so a certain type of radioactivity. And what this does, again, it serves the same purpose. We place these radioactive seeds inside a person's cancer or inside their tumor. And when the seed emits radioactive signal, we have a tool that we use inside the operating room to help take out the area of interest. So again, this is the original seed. It gets placed prior to the surgery, and then it gets taken out with part of the breast as the specimen. So I'll get back to that in a little bit because that's part of my consulting work as well. In the realm of melanoma, also a big part of my clinical practice, totally separate from the breast cancer bit. We know melanoma is a quite dangerous type of skin cancer. And so my job in this scenario is often to remove not only kind of primary melanomas, but also treat people in whom melanoma has spread to other parts of the body. So on the right, see, this is basically someone's entire or half of their pelvis, their groin area. And this person specifically had melanoma that had extended into the pelvis and into the lymph nodes that live here. So I removed all of the melanoma that was here. And what you see left is basically the residual part of the leg muscles, part of the abdominal wall, and all the blood vessels that lead from the pelvis to the outside. So this is a big cancer operation that sometimes we do to rid people of cancer. The cool part of some of this soft tissue work is that we get to remove areas of skin cancer, and then also we work with the plastic surgeons to creatively kind of reconstruct someone's body to get rid of a defect that looks like this and recreate it into something that people can live with. We can't leave people with big holes in their body. That's usually not appropriate. So again, it's kind of a creative way to work in the cancer field. And just like reconstructive surgery for breast cancers gives us an opportunity to kind of play with the skin and soft tissue and fill defects that we create. So a little bit about why I like what I do and why specifically I chose breast and soft tissue surgery within the cancer field. Like I said, I find it a really creative outlet for me. It's a mix of cancer management and also creating cosmetically pleasing aspects of someone's life. I get to work with plastic surgeons, medical oncologists, radiation oncologists, radiologists, pathologists, really a whole host and team of people that do complementary things to what I do. And we get to treat one individual with many different aspects of treatment. So that's really fun for me. As a general surgeon, I did a lot of bowel surgery in my training and in my career already. Bowels, especially the ones that explode, are pretty smelly. So it's a part of my life that as part of my training, but I've kind of shifted away from that. So the stuff I do now really isn't super smelly, which is a nice change for me. Many of the surgeries that I do nowadays are a little bit shorter than some of the bigger general surgery procedures. So often my day can consist of several, 2 or 3 hour procedures instead of an 8-hour procedure. So it makes it a nice day for me. And a lot of my patients are outpatients, so I don't have to deal with a lot of ward care as well. The final thing I have here is, a lot of the cancers that I treat, because they're screening detected, have an excellent prognosis, and I can cure people. And that's a really nice, obvious thing for me, and obviously for my patients, in order to give my life and my treatment purpose, and make it really rewarding on a weekly basis. So I'm going to switch hats a little bit to some of the consulting and industry work that I did and that I do still. Like I said, one of the things that we do, particularly in breast cancer, is localizing cancers that are non-palpable, meaning we can't feel them with our fingers, and use tools to help us surgically take cancers away. So when I first started in my job, this was, like you see here, back in 2014, we were trying to look for a different technique, a different type of way to accomplish breast cancer localization. And so we were using those radioactive seeds that I showed you before. And one of the main issues with that is that introducing any radioactivity into the hospital requires a lot of infrastructure and a lot of procedures and protocols to help keep radioactivity in check and make sure we don't lose track of it. So that requires a lot of people hours in order to do that. So what I was charged with was creating a new type of localization technique that was free of radioactivity, but still safe and useful for patients. And so this came up back in 2014, like I said, and I was collaborating with physicists and engineers within my cancer center to try to do this. And the original project, stemmed many years, several grants, and several phases, extending everywhere from creating a physical prototype to benchtop testing, and eventually testing in humans with a clinical trial to bring our product to fruition. And as I think you're learning in this conference, that process is not short, and there are many back steps and things that don't work. And so navigating that is not always easy. And many products are successful, but they never get into the mainstream because it costs money, quite frankly. So we were lucky to have a philanthropist kind of see and fund our project and create a receptor company, which, as I told you before, is called Molly Surgical. And it's a company that's based here in Toronto. And once we had that company in place with a product that worked, we could then use that product, apply to Health Canada and the FDA in concert. And eventually, we just obtained approvals for this in 2021. So once that came through, I'm still running the scientific portion of this. So some of the larger clinical trials related to the product, but the company was able to take over marketing and education and moving forward with bringing the product into mainstream, which is what we're doing now. So it's a pretty exciting time for us. And I still continue to work with the company as we're, developing other related and totally different products and bringing those hopefully to fruition in the coming years. So this is the original product that I had a big part in creating, working with the engineers and the physicists to do this. And we created not a radioactive product, which is the product that I had mentioned to you before, the little radioactive grains of rice. Molly is actually a magnetic product. So it's just like the fridge magnet that you have at home. And it uses technology within this wand, we call it, as you see here. It uses a gyroscope similar to what you have in your cell phone. It uses multiple of them to kind of situate one's place in three-dimensional space. So we created the marker, the little magnetic marker, we created the detector, and then we created the output receptacle, which is what you see here and what's broadcast on the right side of your screen here, in order to give output to the surgeon so that they know how far away they are to the marker and where to find the marker in space. And so when we put this little marker inside a patient's tumor, we can then use this output in order to locate the tumor in three-dimensional space and then use that to guide where to take out in the future. So that's basically the product that was the inciting product for our company. And I'm happy to answer any specific questions about that, but that's kind of the broad overview of the innovation and consulting work and where that started out for me. So the third hat that I kind of wear is in terms of academics and research, and this is connected with the University of Toronto. So as I alluded to a little bit before, I do a fair bit of work in health economics and health services research, so basically big data and surgical innovation, similar to the Molly project that I showed you before. I do often the scientific side of testing the product, looking for the right outcomes, and looking into post-production research on how to be successful with that. So research works a little bit in cycles. We don't do the same thing every day or every week. So at any given time, on any given week, I have multiple projects going on that are at different stages of design and execution. And I have a whole team of people that work with me on that. From students to research assistants to analysts to other statisticians. And we all work together to do the research part. We have meetings on a weekly basis to plan projects and analyze data. I spend a fair bit of time writing grants and writing manuscripts to give me money to help promote and complete my research. And then I also manage several students and trainees to help me execute these projects. And then often these projects lead to different opportunities that happen more infrequently on perhaps monthly or yearly basis. And these are things like presenting our research at conferences, demonstrating certain surgical innovations in teaching sessions or webinars. And then we also execute and design clinical trials, and these are often done on a provincial or a national level when we conduct research in concert with other universities, just to get more people and to make more impactful research. Another part of academics is with teaching. And so there's obligations when you're connected to a university that require teaching of students, residents, and fellows at different levels. So these are different skill sets, something that we do all the time. I'm also the program director for our breast surgical oncology training program. So I design the curriculum and kind of coordinate some of the administration for that. I also still have involvement with the general surgery residency program, so oversight of that, as there are many hospitals involved with training residents. And then I also have an administrative role in the School of Public Health, directing one of their courses in the clinical epidemiology sector, and also mentoring master's and PhD students to help them bring their projects to fruition. So it's cool because there are many aspects of academics that one can get involved with at many, many different levels of teaching. And so I've had the pleasure to assist with that over time. So the MedVenture organizers had asked me to come up with a couple of different specific slides with respect to how I got interested and inspired to being a surgeon. And that's the next couple of things that I wanted to share with you. So in terms of what inspired me into a career in surgery, I like to work with my hands. And so, for example, I had a lot of musical training in my background. I'm a pianist and a cellist. And so when I was picking careers, I was either going to go into a career in music or a career in medicine. Both kind of heavily work with your hands. And so this uses the same part of your brain, I think. And so that was one of the huge things that I wanted to do with my life. I have a very short attention span and I like to multitask on things. And so I needed to pick a career where I could see a problem, try to find a solution, and then carry out that solution. Logical, quick steps were things that I liked to do. I like simplicity, I like logic, I like pathways, and I like things that make sense. So all of these kind of go with a career in surgery. I found anatomy really beautiful and really simplistic in terms of you could break it down into steps and then use these steps to build more complex logic. And that was really nice for me. Yeah, as I said, I like to make quick decisions and see immediate outcomes, and surgery allows you to do that. And specifically in the types of cancer that I treat, it allows people to hopefully be cured, which is a super rewarding aspect of my life. I also like to be around lots of different types of people who can contribute to analyzing and creating solutions for problems. And so my career, specifically in cancer surgery, allows me to do that. On the flip side, why would I want to be an academic surgeon versus being a community surgeon where I could just do surgeries all day and not have to worry about obligations to the university? So being an academic to me has many benefits. I'm connected to the University of Toronto, which gives me a lot of resources, not only in terms of people, but also in terms of physical data that I can work with. So without that connection, I don't have those opportunities. It also gives me the chance to teach on a regular basis, which I like to do anywhere from students to residents to fellows, to mentoring new staff as they come into practice. Gives me the opportunity to contribute to other people's careers, which is pretty rewarding as well. Like I said, I have a pretty short attention span, so every week in my life is different, and I really like that. I do like some predictability, but I also like to do different things every week and every year. So my academic career allows me to do that and grow over time. I have the opportunity for mentorship, shaping the next generation, and also lots of collaboration, both within my institution and outside, which is cool. There are definitely downsides to being an academic. I definitely make less money than someone who does community surgery does. Surgeons and doctors in general are paid by the government in Canada. So, if you do more surgical work, you get paid more money. It's as simple as that. And so I spend a lot of my time doing academic work that's actually not compensated on a procedural or hourly basis. And it requires a lot of work on evenings and weekends. So I donate a lot of my time, quite frankly, and I don't get paid for it. So you have to be okay with that if you choose a career in academics. As I said before, there's also obligations to contribute to the university and to the hospital. So I have to prove that I'm making contributions on a daily, weekly, and yearly basis. And, there's different obligations on evenings and weekends that really sometimes eat into your life balance. So there are challenges to balancing your career, your family, and also your outside interests in order to be an academic surgeon. Yeah, and I think this is the same for many, many careers. You have to make choices, and you have to be okay with that as you move forward in your life. But this comes with many rewards. And, both as a surgeon and as an academic, there are certainly rewards in what I do every day. So as a cancer surgeon, foremost on my list, I get to treat people and often cure people of cancer. And, there's no substitute for that for me. I'm able to provide very compassionate care to patients and families at a really vulnerable time in their life. And that's really a privilege for me to do that. And I don't take that for granted. You have the opportunity to really make human connections with patients, like I said, at a truly vulnerable time in their life. And, sometimes I'm certainly the professional and taking that role, but the humanness in what we do comes across every single day. And that's really a reward for me. It's really humbling on a daily basis to see patients come to us with problems and needing help. And I'm really grateful to see kind of the strength and the resilience of people every day. And as surgeons, we put people to sleep, we do what we need to do, and we wake them up on the other side. And when you step back and think about it, the trust that patients and people place in us is really quite remarkable. Someone had a question?
I think there were 2 questions by 2 people in the chat. Do you have access to the chat, or do you want me to read out the questions?
Now. Yep. So we had a question from Anna that said, I said that the plastic surgeons are able to acquire through growth skin to cover the excisions. Does the body ever reject the new skin? And if so, how do you tackle this problem? So good questions. We don't really use, at this point at least, we don't really use engineered skin to cover the defects. The most common thing we do is use skin from the same individual, sometimes in the form of things like skin grafts or skin flaps. So using skin from a different part of one's body and transplanting it basically to part of the body that needs coverage. So in that way, when you use your own tissue, we don't have problems with rejection. The other thing that sometimes we do if we need to supplement new skin, we use engineered products, sometimes like animal products, usually based on pigs. But we use the pig skin as a bit of a scaffold, and we kind of use the supporting structures, but we the product that is sold on the market kind of dissolves all of the pig-based product, and therefore produces just the scaffold and not the immunogenic sides that create rejection. So if we do use an outside engineered product, it is treated such that the rejection does not occur. I think if ultimately we're able to, create new organs to transplant into people without issues of rejection, that's obviously something that's being worked on in the industry, but we're not quite there yet. Does that answer your question, Anna? I don't know if you had any other questions related to that.
Yeah, that answers my question. Thank you so much.
Thanks. And Anushka, what do you teach the students and residents, and what is a fellowship? Good question. So different people at different levels need different types of teaching. So basically for students and residents, my job is often during their medical and surgical training is basically teaching them how to be a doctor, right? And as you move through your training, you need different types of mentorship. So for medical students, for example, a lot of that is just teaching them, getting them into the environment of seeing patients, taking histories, doing regular physical exams, and teaching them how to recognize problems, basic problems in surgery. For residents, basically they're in training programs specifically to do a certain thing. So the general surgery residents, for example, they're training to be general surgeons. So as they go through their training, it's usually about 5 to 6 years, they're learning to do specific surgical procedures. So I kind of shepherd them and mentor them through those specific procedures, and also how to take care of patients on the ward. When surgical patients have problems, what do we do about it? How do we recognize emergencies? What to do if there's a complication? For example, if you do an operation and someone has bleeding afterwards, what do you do about that? How do you manage the patient, and how do you fix the problem? So that's often what we're teaching the surgical trainees. Fellowships are training programs that are basically the very end of one's training. So they're learning to do very specialized aspects of your training. It's usually after someone has kind of graduated and is licensed to be a surgeon. So they could practice on their own, but they choose to do a fellowship to get special surgical training. So for example, once I became a licensed general surgeon after completing my residency, I then did a fellowship specifically to learn about aspects of cancer and cancer surgery, and then use that to apply to a more specialized practice. Anushka, does that answer your question?
Yeah, it does. Thank you.
Perfect, thanks. All right, so I was just talking a little bit about what are the greatest rewards in my practice. So cancer surgery has certainly a lot of rewards for me. And then as an academic, it is really the opportunity to have an involvement in the lives of others that makes a big impact and reward for me. So like we were just talking about, actually, anywhere from medical students learning how to talk to a patient for the first time, to fellows who are learning the very fine nuances and details of how to be a specialist. I have the opportunity to treat and to mentor students of all levels. As an academic, I also do a lot of research with people within my neighborhood, but also people across the country and also people across the world. And that seems daunting, but in the right field, it actually is possible. And we attend a lot of international conferences and such like that. So it's really rewarding and really interesting to see what other people are doing all the way around the world. And certainly with the advent of things like Zoom and the opportunities to collaborate electronically through video, we've done surgeries over Twitter, for example. And so there's a lot of opportunity to really connect with people across the globe. Finally, as an academic, it gives me a lot of different opportunities to do different things every week and over the course of years. So I never get bored, and there's always a new thing to kind of look at and embark on as you kind of grow in your career and decide what you like to do within different spheres. So if you are considering a career specifically in surgery, I understand you guys all have an interest in healthcare and potentially in medicine, but specifically in surgery, what I can say is that the training is fairly long. Like I said, it's about 15 years to get me from high school to my first job. So compared to other things, compared to some of your friends and colleagues, that may be, short or long, depending on how you look at it, but certainly takes a while to get there. And if you have other obligations, family obligations, financial obligations, debt, all of those types of things, you got to think about doing the career that you want and doing the career that you like, but also balancing other things that come into your life. Stamina is important. There's lots of long hours. When I trained, it was a while ago now, but there were lots of 80 and 100-hour work weeks. I think that's changed a little bit with newer legislations that have come into place with respect to work hour restrictions for trainees. But compared to other fields, surgery is a field where you need a fair bit of stamina as a trainee and also in your career. Your life will require sacrifice, just like many other careers, recognizing what's important to you in terms of family life, children, other outside interests that you might have. These all have an impact on how you choose your career overall. And there's definitely challenges in surgery. There is many rewards, like I've talked about before, but surgery is a field that I think, while it is moving forward, it is not at the forefront of issues related to, equity and even financial rewards. It is changing, but still is largely a field dominated by white males. And in the course of my training and my career, navigating that as a non-white female definitely had its ups and downs. And like I said, I don't want to be a downer on all of this, and it's definitely a place where evolution has taken place over the past decade. And there are many more females, many more ethnicities, and much more respect for bringing surgical training and practice into, the new millennium. So it's interesting to see that progress, and it's exciting to be part of that and to kind of train and inspire women to go into the field like I have. So there's definitely, like I said, been evolution into female mentorship and encouragement of females to go into surgical training and practice in the realms of Black, Indigenous, and minority mentorship. There's definitely been strides in the right direction to support and mentor many minorities to go into surgery and to be proud of doing that. There's definitely acknowledgement of the presence of bias in how we choose trainees to go into the medical field. And there's, conscious effort on the side of universities and medical school training programs to recognize these biases and try to diversify our medical trainees and our medical students and recognize the benefit that individuals bring to the field. Now, the goals are pushing towards, celebrating diversity and trying to ensure equity for training, and not only for training, but also in, selection and hiring and promotion once you get into jobs. trying to recognize that biases in the workforce exist, and using diversity and equity not only as check boxes, but really things to look for and to celebrate when we look forward to creating training and teams of people that we work with. The last thing I'll mention is that surgical training, like I said, is long, requires a bit of stamina, and requires some recognition that there will be sacrifice. But within that, there is concurrent recognition that balance and wellness needs to be a part of surgical practice. And so particularly in the context of COVID, when certainly lots of challenges have occurred, there is definitely the challenge of bringing holistic wellness into training and practice, and trying to recognize that when people take care of themselves and when we take care of each other in terms of physical and mental wellness, we actually are better doctors, and we bring more to our patients and our work environments. So these are definitely things that we're working on in the field of surgery, but definitely things that I think will continue to evolve within the next many years and decades. So not meant to discourage any of you to be surgeons and to look forward to that career, but just to say this field is definitely in evolution, put it that way. And I think that was pretty much my last slide. So I'm certainly open to questions, on the good things, on the bad things, and any things that you would want to talk about further within the next. I think we have about 8 or 10 minutes left. So I'll stop sharing, and if anyone wants to put their cameras on or have a chat, I'm happy to do so. Let me open the chat here. Have you ever done surgeries where patient is one of your family members? And if so, what is the difference in your feeling between patients and other patients? So interesting question. I have fortunately never had to do any surgery on one of my own family members. And I think, to be honest, it would probably be a little bit of conflict of interest for me. I think I would probably recognize, we're talking about recognizing one's own biases that you bring. I probably wouldn't be the most level-headed if I was having to treat one of my family members. So if that were ever to happen, I would probably ask one of my colleagues to take care of a family member, just to make sure that you separate the professional in you and the personal, emotional aspect in yourself, to make sure that every patient gets equal opportunity. No problem. Was there a perspective, so another question, another message that I had here, was there a perspective turning point in my career, like a certain patient's journey? And I'm not sure if you mean kind of in becoming a doctor in general, or whether this has more to do with surgery or cancer. But I wouldn't say there was one kind of sentinel event where I was like, oh my goodness, this is what my heart is, speaking to, kind of in general. I knew that I liked, when I was in undergrad, for example, I knew I liked science. I knew I liked working with my hands. I knew I liked taking care of people. So that kind of shepherded me into the medical field. And then within that, I didn't know I wanted to be a surgeon for a while. In medical school, you get the opportunity to try out different aspects of medicine in the last few years of your schooling. And so I actually thought I wanted to be an infectious disease specialist for a long time. So treating things like Ebola and COVID. And now I'm super happy I didn't do that, frankly, but those were the times when you get to try out different things and then kind of pick the area that speaks to you. And so I think that's where I figured out that I wanted to be a surgeon. Other questions? What was the biggest challenge? What's the biggest challenge in healthcare right now? Like, what are the biggest impacts of COVID for your practice and your specialty? So in terms of COVID, different challenges have come along over time. So as you probably know through the media, through the first and second waves of COVID, in surgery, there was a lot of shutdowns over the course of several months. So particularly in cancer, that created issues in terms of equity. So how do we manage people with cancer? Are they truly elective surgeries or not? And subsequent to that, how do we manage the backlog? So there were huge kind of provincial and national tables that were looking at how do we share patients across physical and geographical boundaries, and how do we make sure that people's overall health isn't impacted? And those challenges are still going on. The other major challenge that we're facing right now in healthcare is the workforce. So there's not enough healthcare workers to do the work that needs to be done, partly because Omicron is making people stay at home a lot, and just lots of people with COVID, so lots of people in isolation. And secondarily, a lot of people are just burnt out. So particularly in the nursing field, for example, many people have taken early retirement. They've been working so much over the past couple of years that our hospital, for example, has so many problems in keeping nurses coming to work. And that's a huge issue right now, is maintaining the workforce. So it's going to be a challenge for many years to come, I suspect.
Thank you.
No problem. Any other questions? Anna has a new message here. Surgery is widely considered an extremely stressful profession. How do you manage or handle stress, and any tips that have worked for you? So that's a really good question. And I've tried to be kind of honest with you about the fact that it's definitely long hours and requires a lot of stamina over time. For me, it's always been important to have an outside outlet that you can turn to when life is stressful and life is causing you to feel depressed and feel down. So for me, that's always been, a family is obviously important, but for me personally, it's always been music. And so over the course of university and my training, I have always had musical instruments in wherever I'm living, for example. And even as an adult in my professional practice, I take music lessons, so that I'm the student and not the teacher sometimes. And I make time to do performances, play chamber music, those types of things. Something that's just so totally opposite and different from healthcare and surgery, but allows me a little bit of an outlet to be creative, to talk to different types of people, and to have a different type of enjoyment in my life. So I think for me, that's been one of the most important things to managing stress on an ongoing basis. You got to make some time for you and something that makes you happy. So don't forget about that as you move forward. I think the other thing I'll mention to kind of maintaining a balance in my life, over the course of time, you get asked to do many things. And so part of your job and part of your maintaining your own wellness is learning, where your passions are and when to say no to things. So learning how to do that and how to sometimes please yourself and not pleasing other people all the time is definitely a challenge, and something to think about as you move through.
Doctor, I have a question for you.
Okay.
Do you think it's possible for someone to pursue multiple specialties when it comes to surgery? So, for example, working on vascular surgery, and at the same and after finishing vascular surgery, going into pursuing psychology, for example.
I think it's probably possible. Requires many years of training, but I think if you did that, it would have to be with a specific goal in mind or a specific job in mind. And so, for example, there are definitely people who do that to try to mix different types of careers together. In the UK, for example, they don't have separate cancer surgeons and plastic surgeons. In Canada, there are 2 separate training programs, but in the UK, it's one specific training program where one learns all of these skills together. And what that's meant to do is for someone, for example, to take out cancer surgically, but also be able to do all the reconstructive work involved with that. So if you did 2 separate training streams, but kind of married them into a singular purpose, for example, then I think that could work. Yeah, I hope that answers your question.
Yes, doctor, thank you.
There's also people that just change their mind along the way. You know, they think they like something, they do many years of it, and then eventually they lose steam for it, or they want to do something else. There's definitely doctors and surgeons that have gone on to change their program and training and do something else entirely. So I guess that's always possible too.
Yes, I mean, I'm the type of person who sometimes get bored quickly. So I tend to change hobbies, I tend to change habits most often, but that's why I was wondering if that's applicable when it comes to pursuing a career.
Yep. I mean, ultimately, you have to do something you're going to enjoy, and for a good chunk of years for your life. So at some point, you do have to make a decision. And you have to do something that's going to pay you at the end of the week, so you can pay your rent and put food on the table, right? So you obviously have to make a decision at some point, but there's lots of forks in the road and ways for you to pick the path that makes the most sense for you.
Yes, thank you, doctor.
Any other last questions, things I can help with? Elaine, anything else that you wanted me to cover, or
I think that's pretty much it. Thank you so much for coming in today and teaching us so much about like what the day in the life of a general surgeon is like, and you answered a lot of the questions I'm pretty sure a lot of the people are wondering. And yeah, just thank you for taking time out of your Sunday to give us this insightful workshop. Thank you so much.
You're most welcome. Feel free to reach out if any other questions come up.
Yeah, for sure.
All right. Take care. Good luck, everyone.
Thank you. Have a great day, everyone.
Thanks. You too.